Hello everyone, welcome to my channel Mkmedicine. Today our topic is achalasia. Now definition of achalasia. Achalasia is esophageal motility disorder with three major abnormalities. Number 1 abnormality, increased resting tone of lower esophageal sphincter. Number second is aperistalsis, means loss of peristalsis in body of distal two-thirds of esophagus. Normally, peristalsis is esophageal movement. It helps to propel the food from esophagus to stomach when we swallow. Third abnormality is failure of lower esophageal sphincter to relax with swallowing. Means lower esophageal sphincter tone is increased. So even during swallowing, lower esophageal sphincter does not relax so that the food reach the stomach from esophagus. Now the pathogenesis of achalasia. Actually, it results from degeneration of inhibitory neurons in mesenteric plexus. Actually, I want to clear this point that there is a mesenteric plexus, which is a neuronal plexus in muscular wall of esophagus. There are two types of muscles in esophageal wall. One is a circular muscle and other is a longitudinal muscle, and mesenteric plexus is in between these two muscular layers, circular and longitudinal. And mesenteric plexus control peristalsis in esophagus, and it also relax the lower esophageal sphincter during swallowing. And second point is these inhibitory neurons contain nitric oxide and vasoactive intestinal peptide in distal two-thirds. Actually, nitric oxide and vasoactive intestinal peptide cause relaxation of lower esophageal sphincter during swallowing. But these two things, one is peristalsis and relaxation of lower esophageal sphincter, does not happen in achalasia. Now the causes of achalasia. Number first, it's idiopathic, means cause is not known. Number second, amyloidosis. Actually, this is disease in which abnormal protein deposit in different organs of the body, and in same way amyloid protein deposit in neuronal plexus in esophageal wall and cause destruction of nerves, and achalasia occurs. Number third one is sarcoidosis. It's a granulomatous disease in which granulomas occur in different organ and cause inflammation and damage to that organ and nerves. And in same way in achalasia, granulomas deposit in nerves of esophageal wall that control the esophageal motility and damage these nerves. Achalasia occurs. Number fourth one is diabetic autonomic neuropathy. It also causes the destruction of nerves. Number fifth one is Chagas disease. It's a parasitic disease caused by trypanosoma, and it also damages nerves that control esophageal motility. Then pseudoachalasia. Actually, achalasia-like symptoms occur due to cancer of gastroesophageal junction. Now presentation of achalasia. It presents with dysphagia, means difficulty swallowing. Dysphagia is for both solids and liquids, and it presents with weight loss. Nocturnal cough, means cough occurs at night, and regurgitation. And heartburn does not occur in achalasia because of closed esophageal sphincter prevent reflux. Actually, lower esophageal sphincter is so tight that stomach acid does not reach to esophagus, and heartburn. That's why it does not occur in achalasia. Now, diagnosis of achalasia. We can diagnose achalasia by barium swallow. Barium swallow shows bird's beak appearance, means esophageal dilation with uniform tapering of distal esophagus. As this picture shows, esophagus is like bird beak. Proximally it is dilated and distally it tapers off. Another way to diagnose achalasia is esophageal manometry. It is most accurate. It shows decreased peristalsis in body of esophagus, and it also shows increased resting pressure in lower esophageal sphincter. And we also perform X-ray for achalasia. It shows abnormal widening of esophagus, but X-ray is neither sensitive nor specific test for achalasia. We also perform upper endoscopy. Actually, it shows normal mucosa in achalasia. It is useful to exclude malignancy. Upper endoscopy is actually not the diagnostic for achalasia. It is performed to exclude esophageal malignancy. Because achalasia and esophageal malignancy presents in almost same manner. Now, treatment of achalasia. There are two kind of treatments: pharmacologic treatment and non-pharmacologic treatment. Pharmacologic treatment includes botulinum toxin injection. Actually, it relaxes the lower esophageal sphincter. Its effect wear off in 3 to 6 months. Another pharmacologic treatment is nitrates and calcium channel blockers. Nitrates actually relax lower esophageal sphincter, and calcium channel blockers decrease the tone of lower esophageal sphincter. Now, non-pharmacologic treatment of achalasia. One is pneumatic dilation. It is endoscopic therapy for achalasia, in which air-filled balloon pass through endoscope to lower esophageal sphincter that disrupt the muscle fibers of lower esophageal sphincter, which is too tight in achalasia. Another one is a Heller's myotomy. It is laparoscopic surgical procedure that weakens the muscles in the lower esophageal sphincter.